I want to completely change the way you think of and approach a seizure. A seizure is an abnormal electrical discharge in the brain. Something is making your brain unhappy. Seizure equals unhappiness inside the brain plus minus unhappiness outside the brain, which equals threshold. Think of seizures as threshold. For example, I have a very high seizure threshold. It would take something massive to my brain to cause a seizure. Someone similar age to me with primary epilepsy has a very low seizure threshold. So what can be unhappy inside the brain to lower the seizure threshold? For example, cerebrovascular disease, dementia, traumatic brain injury, brain tumors, meningoencephalitis, etc. What can be unhappy outside the brain to lower the seizure threshold? For example, organ encephalopathy, recreational drug abuse, alcohol withdrawal, severe infection or sepsis. Now with that in mind, here are 5 key considerations when treating a seizure. Number 1, and most importantly, what was the trigger for the seizure? What is the unhappiness inside the brain or outside the brain? Number 2, was it a true epileptic seizures? A lot of seizures are functional or Raynaud's sepsis misinterpreted as seizures. Number 3, how bad was the seizure? Was it a small focal seizure, a self-terminating generalized tonic-clonic seizure for 1 minute, or was it a prolonged status? Number 4, how many seizures occurred? And number 5, therefore, what is the risk of further seizures versus the risk of starting anti-epileptic therapy? Now, for example, alcohol withdrawal seizure. It doesn't matter how many seizures it's had or how bad there were. You're not going to start anti-epileptic therapy. You are going to treat the alcohol withdrawal. What if an 80-year-old with dementia from a care home comes in with a seizure due to pneumonia? You treat the pneumonia, they get better. Do you start them on anti-epileptic therapy or not? Risk balance. Now here are 3 key management points. Number 1, anti-epileptics increases the seizure threshold. Other lifestyle interventions are as important, such as good sleep hygiene, avoiding triggers that can cause a seizure with a diary, stress, alcohol, recreational drug use, etc. Number 2 is time. The risk of a seizure is highest in the first month after the acute insult, and afterwards the seizure threshold would increase. This explains why sometimes patients are discharged with an anti-epileptic followed up in seizure clinic after the first month to see if they can be weaned off the anti-epileptic if they have been seizure free. Number 3 is anti-epileptic therapy. Now the most common anti-epileptic started in hospital is levetiracetam or lamotrigine. Levetiracetam is good because it achieves therapeutic effect within days. However, it has the side effects of mood disturbance or headache. Mood disturbance is particularly problematic if you've got underlying dementia, mental health disorders. Lamotrigine is safer with fewer side effects than levetiracetam, but it takes weeks to get to therapeutic effect. So try this out next time you see a patient with a seizure. And don't forget to subscribe.